Wonderful. Hi, everyone. Thank you for joining us today for our Rural Health Work Group. My name is Christy Degner, and I am the Site Engagement Coordinator for MVC. I look forward to facilitating this work group for you all today. So today's Rural Health Work Group will feature a presentation by Dr. McGreaham and Joyce Fetrow of the Northern Michigan Opioid Response Consortium, a community-based organization supporting 25 counties in Northern Michigan in efforts of prevention, treatment, and recovery from substance use disorder. Dr. Dave McGreaham previously practiced internal medicine and then was the Chief Medical Officer of Munson Medical Center. Dr. McGreaham currently works as the contracted medical director of the Northern Michigan Opioid Response Consortium. Dr. McGreaham is also a member of the Grand Traverse County Drug-Free Coalition, Face Addiction Now Grand Traverse, and chair of the Grand Traverse County Opioid Settlement Task Force. Mrs. Fetrow is a woman in long-term recovery, a certified peer recovery mentor, a recovery coach professional and facilitator, and a community health worker. Mrs. Fetrow currently serves as the project director for the Northern Michigan Opioid Response Consortium. Additionally, Mrs. Fetrow volunteers in her community in several ways. She is the board president of the Otsego chapter of Face Addiction Now and serves as board secretary for the Refuge in Gaylord, Michigan. In 2021, Record Eagle Traverse City recognized Ms. Fetrow as one of the influential women in Northern Michigan. In May 2024, Michigan Association of Treatment Court Professionals presented Mrs. Fetrow with the Hero Award for her efforts in the Otsego Recovery Court. Thank you, Dr. McGreaham and Mrs. Fetrow, for being here today. Before you begin your presentation, I have a few housekeeping items to review. So first, this session is being recorded. The slides and the recording will be shared with all attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Dr. McGreaham and Joyce's presentation for an open Q&A and discussion. And then lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat at the end of the work group, as well as in an email sent following the work group, that would be greatly appreciated. And as a reminder, for hospitals participating in P4P who would like to receive credit for this work group, this survey is mandatory. Please note that the hospital that you're attending on behalf of so you can appropriately receive credit, and please make sure you're only completing one survey for this work group. Thank you so much for being here, and without further ado, I will pass it over to Dr. McGreaham and Joyce. Thanks so much.
Yeah. Okay, I can hear you now. I transferred you guys to my phone. Sorry.
Well, welcome everyone. I'm first going to get started just by providing an overview of who and what NMORC is. We started back in 2018 with a planning grant through HRSA to develop out a work plan that would be used going forward. And how we would use that work plan. We currently today, since 2018, manage 5 different grants. We have a behavioral health grant, working on a couple of extensions on some other grants, and then we have a grant to address psychostimulant use, polysubstance use, and stimulant use in the targeted counties that we have there. When we first started with our planning grant and our implementation grant, the reason why and how we selected the 25 counties that we serve today was due to poor economic factors, poor health conditions, social and behavioral barriers, prescribing patterns, and then also high prescription drug use. And then the unfortunate part, high overdose deaths and occurrences. When we looked at doing this, one county stuck out in particular, and that was Roscommon County back in 2018. And in that county, with all the residents combined, there was enough prescriptions written to give every man, woman, and child at least a 30-day supply of narcotics. So we definitely had some improvement to do there, and we've done a lot of that improvement. Our work plan that I spoke of for our grants focuses across several different buckets: prevention, treatment, recovery, workforce, and harm reduction. Workforce is not only addressing the behavioral health shortages and gaps that we have in our 25 counties, but it also takes those individuals with lived experience and gets them integrated into the workforce, working in health departments, treatment centers, detox centers, hospital ER departments, anywhere where we can implement a peer recovery coach to support the community is very favorable. Prevention, the Families Against Narcotics, that's an organization that has now changed their name, so I apologize for that. We need to make that correction. It is now Face Addiction Now, and Dave and I both serve on 2 different community chapters. We do try to implement more of those chapters, but we have 2 that are going really strong right now in our region. We partner with Kirsten's Ride to provide assist trainings, which is applied suicide intervention skills training. We do a lot of work with medication safety and disposal, getting rid of those unused medications and keeping them out of the hands of the unintended. And then Dave does a lot of pharmacy visits and leverages a tool that we have, academic detailing, where he can work almost on a peer-to-peer basis and provide some education to either clinical offices and pharmacy visits, but comes better from someone like him than from someone like me with no background in education. And then we really want to saturate all of our communities with Narcan accessibility. We do that in several different ways. We promote the MDHHS portal where you can order naloxone, Narcan for free. We have naloxone distribution boxes that we have integrated in several different communities and several locations. Those are an upcycled newspaper box that we can stock with Narcan and get them in front of businesses, sidewalks, vestibules, entryways, of just about anywhere that we can get them placed. And we do a lot of education and providing funding support for that education, such as EMDR training for therapists, or DBT training, or ACT training for those working in those clinical spaces. And then, of course, we can't address the opioid crisis without addressing medications for opiate use disorder. So at one point, an individual who wanted to seek that type of medication to aid in their treatment and recovery from opiate use would have to go to a specialized clinic. These days, any healthcare provider can start prescribing that medication and increase that accessibility in our communities as well. So there's no more that need to drive long distances one way or round trip just to receive a medication. We've been able to increase that capacity, serving those people that need it. On the recovery side, we do a lot of technical assistance and helping and supporting those who are interested in implementing recovery housing. Recovery community organizations, those are peer-led organizations by individuals with lived experience. They're generally based in a community, and they work to resolve obstacles and barriers maybe that that community is facing, whether it might be stigma or increasing peer recovery support services, increasing multiple pathways to recovery, or looking at even recovery-friendly workplace initiatives. One of the things that we started back in 2018 is when we kick off our summit meeting or our quarterly meetings, we always invite an individual with lived experience to share their recovery story. We feel this greatly reduces stigma that follows that, but when we can humanize these stories and show powers of hope and where people have been able to transform their lives and turn things around, it really energizes our communities and our consortium members to go out and do more great work. And I talked a little bit about workforce, of course, getting those individuals with lived experience integrated into the workforce, but we also leverage the Department of Labor and Economic Opportunity to increase workforce shortages and look at educational components, making sure that our educational institutions are providing the education needed for people to get degrees. And when they get those degrees, are they fully equipped to get jobs when they complete those? And sometimes that's not always the case. there's some training components that are still needed. And then NMORC is a grant project under the Michigan Center for Rural Health. Michigan Center for Rural Health is a nonprofit state office addressing rural health. We partner with Page Recker to also look at different workforce strategies, increasing those capacities as well. And then funding opportunities, we provide a lot of funding back out into our communities, to our clinical spaces and our consortium partners. We provide leadership development training to our peer recovery coaches. There's just a couple of different ways that they can do that. EMDR and DBT training for therapists. We support the increase in capacity of community health workers. Last year, we trained over 17 community health workers that are currently working as staff in many of our consortium partners' locations. And then we provide mental health first aid training. I just call out that we do the adult version. Our local public health departments primarily provide the youth version. But last year we did over 7 trainings. We trained over 140 people in that curriculum. A lot of those trainings, or quite a few of them, I believe 4, were done within our tribal organizations. And then we provide funding support for anyone wanting to host Recovery Month events or any recovery-friendly event. And a little bit about community collaboratives. All of our team is involved in one of the community collaboratives in one way or another. So we kind of divvy those up and have staff assigned to those. We do have a small staff, so it's just myself, Dave, and 2 project associates, Jean Marriott and Jenny Grover. And we try and balance those efforts as much as possible. We have some community education opportunities. We've given presentations at Rotaries, libraries, and community forums, platforms such as this. And as far as healthcare opportunities, many of the trainings are Summit, provide continuing medical education credits or continuing education credits. And then we partner with Michigan Center for Rural Health to host some social work grand rounds. Jenny Grover has been doing that. It's a 6-part behavioral health webinar series. Those are recorded and also published on YouTube. So if you missed those, I guess one way to find out some of these opportunities is to put your email address in the chat box, and I'd be happy to write that down. And we can get you added to our newsletter and distribution lists if anyone is interested. And overdose fatality reviews, this is kind of new. This is an initiative through Michigan Public Health Institute, something that we've been partnering with them on. We're in the process of implementing one in Grand Traverse County, and that's going fairly well. We leverage medical examiners in that work, but we look at how we can improve practices to prevent those drug overdose or alcohol overdose deaths. And then we provide technical assistance to increasing recovery housing. Back when we started in 2018, in the NMORC region, we had 3 recovery houses. Today we have over 15. And a lot of those are, a couple of those are connected to some of our treatment centers. So once they complete inpatient treatment, they have a stable living and environment to go to that is very recovery friendly, with a lot of structure to it. And I've already covered the one, just having people share their recovery stories, not their addiction stories, to reduce stigma in our communities. So is there one more slide for me, Dave, or is it go to you? Oh, my last slide.
Excellent.
I knew there was one more. We will be hosting a rural Michigan opioid and substance use summit July 25th. That'll be at Treetops Resort. Again, if you want to receive email communications on our events and meetings, things like that, please put your email in the chat box. We'll make sure that you get all the up-to-date information. And then when I finish speaking here and Dave's speaking, I'll put the link to register to attend our conference. So great lineup of speakers. We'll have a provider panel, question and answers. We'll have Michigan Public Health Institute speak on recovery-friendly workplace initiatives. And then our keynote speaker is Dr. Alex Ellswick, just to kind of generate some more excitement with that summit. And with that, I'm going to turn it over to Dave.
Thanks, Joyce. As mentioned, I'm Dave McGreaham. I work as the medical director of NMORC. I'm from Traverse City, and I'd like to elaborate a bit on some of the points that Joyce has already talked about, and also talk a bit about substance use disorder, the scope of the problem, and what we're dealing with in rural Michigan and around the rest of the state and the country for that matter. I think a lot of you have seen graphics like this that show the scope of the overdose death challenge in the United States. We are currently at about 107,000 overdose deaths. We've more than doubled since 2015. And over on the left, if you look at the state of Michigan, we're hovering around 3,000 deaths a year. Many of you have probably also seen this graphic, which shows the drugs that are culminating in the overdose deaths. And if you look over time, you can see that heroin has kind of flattened out and gone down. Prescription opioids have flattened out and even gone down a bit. Methamphetamine, cocaine are rising, and fentanyl is one of the big challenges now. If you look at meth and cocaine and add those two up, they're about equal with fentanyl as far as causing overdose deaths. The challenge is that a lot of the overdose deaths are polysubstance deaths. It's not just one or another of these, it's multiple substances in a person at any given time during their death. We've done some deeper dives into some county data, and these are just examples of some of the data we get out of the databases that we look at. The blue is the number of naloxone administrations by EMS, Emergency Management Services, and the red is suspected drug-related deaths. This is Wexford County, which includes Cadillac. This is Grand Traverse County, which is the most populated county in the region. And you can see that Grand Traverse County looks like it's moving in the wrong direction. Up to 36 overdose deaths last year and a lot of Narcan being administered. Philip Seymour Hoffman, many of you know this actor, died 10 years ago. His death raised a lot of awareness in people regarding the scope of the problem with heroin and other substances. And Mr. Hoffman was found dead in a hotel room with a needle and syringe containing heroin hanging out of his arm. Now we're dealing with fentanyl. And a lot of you have probably seen this picture from the DEA. This is the amount of fentanyl that can kill an average American. Fentanyl, therefore, has to be diluted with substances like baking soda or various types of sugars so that it can be injected or snorted. Counterfeit pills are big in the press now, and they've hit a lot of markets. They're everywhere. And you can see authentic oxycodone or OxyContin, and this is a counterfeit pill. Really hard to tell these apart. 70% of the counterfeit pills on the market now contain fentanyl, and they can be deadly. We've also been hearing about xylazine, which is a veterinary tranquilizer, also called Tranq, and medetomidine has been found in a couple of Michigan communities as well, similar to xylazine, but it's about 10 times as potent as xylazine. And what these additives do is they enhance the feelings that people get from fentanyl and are typically mixed with fentanyl, and that combination can be fairly deadly. So these are the new faces of addiction and some of the deaths that we've seen. These are from USA Today. A teenager on the left, counterfeit pill Percocet that had fentanyl in it, and the teen on the right thought she was getting Xanax for anxiety, and that pill also had fentanyl in it. Just want to remind people that addiction is a treatable chronic medical disease like high blood pressure, diabetes, any of the other chronic diseases, and it can be treated as successfully as other chronic diseases with the right resources. The difficult thing about addiction is there's this complex interaction among your brain circuits and your life experiences that really make this a challenging disorder to treat. And I want to talk just a little bit about the pleasure and reward centers in your brain. Deep in the brain, there's a substance called dopamine, which at baseline, say is at a level of 1. If you do something pleasurable, if you eat, if you exercise, if you have sex, it might pop up to 2. If you drink alcohol, if you have a cigarette, it might pop up to 3 times baseline. If you have heroin or fentanyl, it'll pop up to 4 or 5 times baseline. If you use methamphetamine, it'll pop up to 10 times baseline. So dopamine makes the brain feel good. The frontal lobes that involve judgment, memory, and a lot of other functions start wanting that dopamine surge. And over time, if it doesn't get that dopamine, it will crave it. And the neurochemistry of your brain will change, and actually the structure of your brain will change. And at that point in time, addiction and using those substances is not a choice. It's something you have to do to keep from feeling sick. The treatment of substance use disorder, many of you are probably aware of these approaches. It's multifaceted. Some people need to go into residential treatment. People need counseling, and we have a dire shortage of counselors in the field of addiction, not just in rural Michigan, but almost everywhere. Maybe not as bad in the urban areas. Recovery coaches, Joyce also mentioned those, and they can be key to plugging people into support groups and other resources that they need to get them through their recovery successfully. Case managers, recovery housing, employment, transportation, these are all factors that can weigh into the success of somebody getting through their recovery successfully. And I want to talk a little bit about medication, and Joyce already mentioned this. 3 major medications or medication classes that are used to treat opiate use disorders. And what these drugs do is they alleviate the craving for opiates and other substances, and they help the brain stabilize and get back to normal. So Vivitrol is one of the antagonists that's given typically as a monthly injection. Methadone, which most of you have heard of, has been around for a long time. It's given out in a select variety of clinics. There are 2 in northern Michigan, both in Gaylord. And then buprenorphine, or Suboxone is the brand name, and there are some other brands as well. Works very well. And is available for any practitioner to use, as Joyce has mentioned. If we look at an example of access to Suboxone or buprenorphine, I just pulled a few counties from our region. Benzie County, only 2 patients that were getting Suboxone got their prescriptions in Benzie County. About 181 people in that county are using Suboxone. These numbers don't include methadone and don't include Vivitrol. This is just Suboxone and some of its similar medications. Manistee County, 773 patients got prescriptions in the county, about 356 in the county that use those prescriptions. So Manistee County is serving a couple of adjacent counties as well as the presumption. Wexford County has some access issues. Not as many people can get their medications in the county as are getting therapy. Grand Traverse, more prescriptions written than patients in the county. So again, providing access for the region. Total region, it looks like we have reasonable access. These numbers are up about 1,000 from 2020. So more people are getting medications for opiate use disorder. And it looks like, at least in our 25 county region, people can get access to the medications they need within the region, but often they have to drive to another county to get them. We've tried to make it easy for new providers to do MOUD in their office. We have a grant to help providers do that. That is through Munson Healthcare. We work with the Michigan Open Group. They come into your office. They'll bring policies, procedures, educate your staff on how to treat people with substance use disorders. There are also a variety of mentors that we can plug people in to discuss tough cases with and help them get started. And there's a lot of educational opportunities regarding how practices can get started using buprenorphine or Suboxone in those practices. Another way this is happening is mobile clinics, and this is through Addiction Treatment Services in Traverse City. They go to 4 adjacent counties to provide addiction services. This van is driven by a recovery coach, and there's telemedicine capabilities within the van where people can call back and talk to a nurse practitioner who can manage their medications for opiate use disorder. I want to talk a little bit about Narcan and what we're trying to do. And Joyce mentioned flooding the region with Narcan. It's now gone over the counter, and you can buy it on Amazon for about $30. Or you can go to eBay and get it for $20, or you can get it in your pharmacy for about $45 over the counter. What we've tried to do is leverage a wide variety of resources to get Narcan out. And I want to talk first about what we call community outreach. This references organizations like Harm Reduction Michigan and your local health departments. Those encounters with people are typically with folks that are using illicit substances. They're giving out Narcan, they're giving out clean needles and syringes, they're giving out condoms, they're giving out test strips for fentanyl and for xylazine. This is the most important way to get Narcan out to the community because, again, you're getting it right to the people that are using illicit substances. Another way to get Narcan, your doctor can write a prescription for it. Your pharmacist has standing orders through the state. If you come in on a high dose of prescription opioids, they can recommend that you get a prescription for Narcan. The problem we saw is that there are high copays for Narcan. Even with insurance coverage, it's typically $30 to $50 out of pocket, and now it's about $45 over the counter. So those barriers still exist. 911 and the healthcare system and the first responders, I want to mention, police officers about 80 to 90% of the time are first on the scene with a 911 call for an overdose. So they give a lot of Narcan, and those numbers are not tracked. EMS at the scene now can hand out Narcan to people that have overdosed and are resuscitated, or to bystanders or family members that want it. Not every EMS organization is doing this, but almost all the medical control authorities in Northern Michigan have the authority to do this now and have folks trained through a state grant to do this. The medical community, most of the ERs in our region, I think all the ERs in our region, if somebody comes in with an overdose, is stabilized and wants to leave, or is deemed stable enough to leave, the emergency rooms will give them Narcan, or will give family members Narcan to take home. So that's another good way to get Narcan into the high-risk population that might need it again. A lot of ERs also have access to recovery coaches. Several of the ERs, the recovery coaches will come right to the ER and will plug people into treatment and recovery resources before they leave. Let me talk about these other options as well. We've had an initiative where we've been disseminating what we call naloxone safety kits, or red boxes throughout the region. And these are wall-mounted kits. And this is an example of a kit in the Gaylord Library. We think that anywhere that there's an automatic external defibrillator, there should be an overdose safety kit. If you think about it, with AEDs or defibrillators, we are asking the public, or giving the public, the option to be a first responder if somebody has a cardiac arrest. Likewise, if somebody has an overdose, we think that members of the public should be allowed or have this as an option to resuscitate people, because a family member or a friend may be the person that knows that somebody is passing out from an overdose. We have these in about 40 libraries, about 160 school buildings, a variety of other places where there are public gathering places or defibrillators. And we've got about 330 of these around the region now, and we're constantly looking for other places to put these. As far as the school systems, those in green, the intermediate school districts, we've covered pretty well completely. The ones in the yellow, we've partially covered. The ones in red, we haven't contacted yet, but We've made a lot of progress. We still have some work to do, but we're hitting the schools pretty hard. I want to talk about naloxone vending machines also. We've got the classic vending machines that started getting disseminated probably 3 or 4 or 5 years ago through a grant from Wayne State University, and they're in multiple county jails and some other public places. But Harm Reduction Michigan came up with the idea of, rather than using a big vending machine, let's repurpose newspaper periodical boxes and use those. They're much easier to get in and out of places, and they're much less expensive. They have, I would say, between 100 and 150 of these statewide now. We have at least 40 of them in our region, and we have some funding to support organizations that might want to have these placed outside of their facility. And we have them in places as listed here. We are also trying to get these into health clinics and health centers and outside of hospital emergency rooms. We think that's an ideal place for these because it's a safe place for people to pick up Narcan. There's a lot of people in emergency rooms that may have substance use disorders or know somebody with a substance use disorder. So we continue to try to work with our healthcare facilities to get these implemented. And if you look at a map of the states, this is where they are. They're scattered all over. And if you don't see any in your city or region, we have some contact information that you might want to touch base with us on. Also mentioned pharmacies, and as we had worked with pharmacies about getting free Narcan for their patients, we came up with this handout that we've been leveraging in pharmacies, as well as some healthcare clinics and other places. If you go to this first website, and I'm not going to go to every website here, but if you go to the first website, you watch about a 4-minute video on how to give Narcan, and they will send it to your home for free. You can also go to this first website, and they have an area for syringe safety programs. And if you have a patient or know somebody that needs clean needles and syringes to prevent hepatitis C or HIV, Next Distro will also send them a 30-day supply of needles and syringes to their home for free. Some other things going on in the region, some innovations. This is a wellness response team, covers 7 counties, overseen by Catholic Human Services. These teams will go right to a person's home that is at risk for an overdose or who has overdosed in their home. And they also have several of their recovery coaches going right into ERs in the region to make contact with people that have overdosed. And then there's the Michigan State Police Angel Program. If you or if somebody doesn't know how to get plugged into a system, they can walk into a state police post and ask to get treated for their substance use disorder, and arrangements will be made for transportation to an open facility. And a person called an angel comes in and helps with that process. It's a good way to get people plugged in when they really don't know where to go. So what can you all do? Keep in mind that these are chronic diseases that are treatable just like any other chronic disease. Advocate for resources. Get funding for needed counselors, recovery coaches, others. Help us get naloxone everywhere, including the safety kits or the vending machines. Consider looking into an overdose fatality review group in your county. Consider educating your medical staffs regarding what's going on with substance use disorders, your boards, your administrative staffs. Consider your clinics getting educated in mental health, first aid, and in general, all the community initiatives that Joyce and I are part of need healthcare providers, healthcare people to be part of them to help move that work forward. And if any of you know of any healthcare groups or folks that want to hear more about substance use disorders, we'd be happy to talk to whoever you'd like us to talk to. And with that, this is our team. And I'll open it up for questions for Joyce or I.
Dave, there was one question. Well, there's 2 questions. One of them is tramadol safe for chronic pain medication for elderly? Go ahead and address that one.
Nothing is completely safe, but tramadol is probably the equivalent of a Tylenol with codeine. And Tylenol with codeine is often overlooked. It's very safe. Tramadol is very safe. It has to do more with dosing. If you're taking 2 to 3 tramadol a day, that's a pretty safe dose to take. And our goal with narcotics and chronic pain, we might have gone a little overboard. There are people with chronic pain that need opiates, but they need them in safe doses. They need them in smaller doses than we're maybe historically used to giving. But I don't want people leaving this thinking that opiates are a bad thing for chronic pain. They can be a lifesaver for some people, but the dosing should be safe.
Next question was, and I'm sure this is one that you'll like to talk about, is at what age in the school systems do you begin the education regarding Narcan, middle school or high school? And I think it's important for us to share the story where we had, I think it was one of our partnering agencies providing how to administer naloxone Narcan, and a student actually corrected them and said, look, if that person isn't revived in a few minutes, you need to be giving them that second dose. So I think that was a middle school student, correct, Dave?
It was a high school student.
High school, okay.
I think it's sometimes challenging to get into the schools. There are so many things that the schools are trying to educate students about regarding health. And with teens, it's alcohol, vaping, and marijuana are the big three. Opiates are fourth or fifth, maybe even behind social media addiction. But I think at least by 8th or 9th grade, people should be hearing about naloxone. Messaging with teens, really with the counterfeit pills. I think a lot of teens, if they hear the conversations, they're pretty savvy to counterfeit pills. But I think the way to motivate teens to have Narcan is to kind of encourage them to maybe have it available to save the life of a friend. Because people do use counterfeit pills, people use other street drugs. So if you can save a friend's life, that's a great way to do it. You have to work with parents as well. Not every parent's going to want their son or daughter to have naloxone available because it may bring out mixed feelings in the parents. But I think parents need to have those conversations with their kids. And I think Narcan should be in every first aid kit, should be in every vehicle. It should be something that we all have available just in case we need it.
So thank you for Catherine and Christy for those two questions. The next question was from Elizabeth. Elizabeth, your question was in regards to for the hospitals that have successfully placed vending machines on campus, have they had any barriers from a regulatory aspect? Yes. We in our MWORC region have not successfully placed any vending machines on hospital campuses yet. I do see that Corewell Health is attending. They are one of the healthcare systems that have been successful in doing that, and we are leveraging them and their expertise in order to move forward in our region. And Dave, do you have any other thoughts on that?
Corewell Health move forward, U of M hospitals move forward. What the Joint Commission, my understanding of what the Joint Commission wants, they don't want to regulate over-the-counter drugs, and they are not in the business of regulating non-patient care encounters. So what I'm hearing is that the Joint Commission wants to see a policy on Narcan in public places, and they want to see a process for doing it, but that's all the Joint Commission wants. We've had some challenges in some of our regional healthcare systems. We don't have a policy we can share with them. If Corewell Health would share it with us and we could pass it along, that'd be great. But I just recently had some discussions with some folks at Munson Healthcare about moving this forward again. And again, it just requires probably a clinical pharmacist to develop a policy and make sure that policy is followed like any other Joint Commission policy would be. But if you think about a hospital pharmacy, even over-the-counter medications in a hospital pharmacy. The Joint Commission is not going to look at what's being given out over the counter or given out in a hospital pharmacy that may have public access.
Great questions. Thank you so much. Does anyone have any other questions for Dave or Joyce? Okay, I don't see anything in the chat. I don't see anyone unmuting. So thank you so much for your presentation and presenting this important work. Jessica, do you have a question? You are just unmuted.
Oh, no, sorry.
Oh. A few comments in the chat. Wonderful presentation. Thank you for sharing your work. I echo that. This is extremely important work. Thank you for all your dedication, your time to moving this forward.
Thanks for having us.
Absolutely. So as Joyce mentioned earlier, if you want to post your email in the chat, if you want to receive their newsletters or any email communication, feel free to do that. In our follow-up email, we also will be including Joyce and Dave's contact information. So after the fact, if you want to email them and get added to that newsletter, if you have any other questions, they were gracious enough to include that contact information for any follow-up questions. Before we conclude the work group today, I just want to bring up my screen again and share some dates for the remainder of the Rural Health Work Group series, sessions, and then some upcoming events. I do see a question from Lisa Long. Yes, the slides will be posted in an email, and then the recording is posted to YouTube. So everyone who is attending right now should be receiving a follow-up email with the slide deck and the recording. And then the recording is publicly available on YouTube if you want to pass it along to anyone in your organization who wants to view it. So let me go ahead and bring back up my slides. Sorry about that. Here we are. Okay, so on the screen here, you can see the remaining work group, rural health work groups for this series. So our next one is going to be on September 26th. And then following that, our last rural health work group of 2024 will be on December 12th. As a reminder, to receive the 02.5 points for this work group series, you either need to attend all 4 rural health work groups or a combination of those rural health and health and action work groups to get up to the 4 total as well. Another reminder, in order to get that credit, you do need to participate in at least 80% of the work group session. And then on the screen now, you can see some upcoming work groups. So actually pretty timely. And our next work group will be the Opioid Prevention Engagement Network, and they're going to be presenting on their initiatives on July 9th. And then following that, the second work group for July will be on July 25th, and that will be a sepsis work group featuring McLaren Oakland Hospital's formation of a Sepsis Excellent Committee. As a reminder, all work groups occur virtually from 12 to 1 p.m. And with that, we will conclude the work group for today. Jessica or Emily, if you have the post-work group survey, if you wouldn't mind posting that in the chat, we'll give everyone a second to grab that. If you can't grab it now, if you're on the phone, you can't see the chat, we will be including this post-work group survey in the follow-up email. So